Welcome to EmCyte's Webinar Series. Join us as we explore the latest clinical insights and the science behind precision biologics.
All right, I think we can get started. All right, good evening, everyone. Welcome to EmCyte's Regenerative Edge webinar series. We're happy to have you. I'm Natalie Stevens. I'm the Scientific Director of Biophil Scientific Research, which is the research arm of EmCyte Corp. Biophil has been working closely with EmCyte and supporting their research program for well over a decade. And this webinar series, as you know, is a part of EmCyte's commitment to the scientific advancement of regenerative medicine. The webinar series will focus on different subspecialties, clinical applications, and the use of various biologics for each episode. And tonight's episode will be focusing on the use of PRP and nanofat in scar tissue management. So the format of the series remains the same. We start off with two talks, two different speakers. We'll have a live Q&A following our talks, and then I'll just ask for a little bit of your time for a handful of announcements for just a couple of minutes, and then we'll wrap up the evening. So to get started, I won't delay because I'm sure we're all excited to get started with the talks. So I'll go ahead and I'll introduce our first speaker, who is no other than Dr. Randy Miller. And so Dr. Randy Miller is a board certified cosmetic and reconstructive plastic surgeon and one of the country's leading innovators in aesthetic surgery of the face, hand, breast, and body, as well as a pioneer of reconstructive surgery and stem cell procedures. Dr. Miller sits on and has led various committees, organizations, foundations, you name it, including the Miami Society of Plastic Surgeons, Florida Society of Plastic Surgeons, and the Plastic Surgeons Patient Safety Foundation. The list goes on. He is a co-founder of the American College of Regenerative Medicine, which is a multi-specialty interdisciplinary organization for the safety and advancement of stem cells and regenerative medicine. Dr. Miller is internationally recognized. He's a global expert. He has trained physicians all over the world. He has performed surgeries all over the world, and he has collaborated extensively worldwide across continents. And we're thrilled to have him here. We're excited to hear his talk, and I won't delay any further. I'll let you hear from Dr. Miller himself, and I'll hand over to Dr. Miller now.
Okay, thank you. And just so you know, I'm just getting messages on my, uh, on my screen to say admit people to the Zoom. So I'm not sure if I'm going to be sharing my screen, but I'm not sure if I'm hosting at this point. But I admitted everybody that they asked me to. But I just want to let you know that that's the way it's coming in. So just so you know. Okay, thank you very much. My name is Randy Miller. I'm a plastic surgeon, and I guess Natalie, will I be able to share my screen? Is that how that I can?
Uh, yes,
So
you
you,
can
you
go
have
ahead.
access.
Okay, great. Okay. So basically, what we're going to be talking about today, thank you very much for the kind introduction, Natalie. I would say that my mother probably would not have introduced me as well as you did. So she's fired, and you're the new replacement there. But anyway, I'll break that to her gently. But anyway, what we're going to talk about today is the use of biologics for the treatment of mature scar tissue. And, I think the important thing here to understand is that in the current medical textbooks and what medical students are being taught these days is that there is no treatment for scar tissue. There's nothing to make scar tissue go away. We can use steroids, and steroids are bad for your tissue. They can kind of make everything go away and kind of destroy everything, but it's not really in the best interest of the patients. So, these days, through COVID, we saw that mature scar tissue in the lungs And and even in these cases that I'm going to show you today, shows that the adipose-derived stem cells, exosomes from stem cells, and also the secretome from PRP from the platelets actually combine to have a very powerful anti-fibrotic effect. So these are my commercial disclosures, and none of them will have any real impact on the content of my talk, but it's important that we list those in the beginning. Um, and so now, what we're going to talk about today is like regulatory information. What are exosomes and EVs? What are they? What is microfat and nanofat? What is PRP? And that, there's lots of different variations of PRP, and why combine microfat, nanofat, and PRP? What is the scientific rationale for that? And then what are the treatment protocols, and then what are the particular outcomes? So we know that, stem cells will release exosomes by exocytosis. Basically, they're little bubbles that are being released from the stem cell itself. We used to think that the stem cells would dock to the tissue, and they would terminally differentiate into that different tissue and stimulate the production of new tissue. We learn now that it's not really the stem cell, it's the exosomes and the EVs that are basically being sent by the stem cell to the recipient tissue to do their work. And just as an aside, this is not really included in this lecture, but we're working on some drug development right now, and the scientists are asking, what is the half-life of an exosome? What is the half-life of something in the secretome? And we say it's probably with 20 to 30 minutes. And the scientists say, well, why is it that you're seeing changes in the scar a year later, a year and a half later, 2 years later? Why is that regenerative process still happening? And we think it's because the exosomes basically deliver the cargo, the signal, to the recipient tissue, and then the exosome goes away. The exosome job is done. And then the cargo is in the recipient tissue to continue all of the magical effects of stem cells and regenerative medicine. So, we're talking right now about allogeneic exosomes, and allogeneic exosomes are really approved only for topical application. So if you take a vial of Benev, or you take a vial of Rion exosomes, you can't use that. You can't inject that into the tissue. You can only use it topically, only for cosmetic indications, not improved for injection or infusion. And not necessarily even approved for microneedling. So we're doing, there's no off-label use for the indications for these exosomes or EVs that are in a vial, because there's no on-label indication. So if there's no on-label indication, you can't say that you're using these exosomes off-label. It's not, there is no label. So these are things that are regulated by the FDA, and we cannot use allogeneic exosomes for anything other than topical applications in aesthetics. So autologous exosomes and EVs, I guess I should say EVs as in not just exosomes, but even those particles that are larger than exosomes, which are secreted by platelets, but all of the extracellular vesicles and MSCs that are autologous, you can inject those anywhere in the body. Okay, these autologous EVs and MSCs are from adipose. They're also derived from platelets. Platelets have a huge number of exosomes, which are smaller than 200 nanometers, but they also have lots of other components, such as apoptotic bodies and other things in the secretome that are very, very effective and can be injected, because they're autologous. So they're for medical indications. They're approved for injection anywhere outside of the blood vessels, outside of the, in the extravascular space, but only with minimal manipulation. There are no off-label uses or indications, and they're considered to be the practice of medicine, which is, basically regulated by the Board of Medicine and not by the FDA. And again, these are for injections limited to the extravascular space, not for IV infusion, but for soft tissue injection. So this is a milestone paper that came out identifying MSCs in adipose tissue in 2001. And this is kind of a landmark paper to really help us understand that there are actually stem cells in adipose tissue, and that there are more stem cells in adipose tissue than any other tissue in the body. And the reason is because the stem cells are located in the perivascular network. So each adipocyte has its own capillary, and with that capillary comes lots of pericytes. And the pericytes in the perivascular network are the stem cells. So that's why adipose tissue is the most well perfused tissue in the body. It's the most vascular, and there are tons of blood vessels going to each adipocyte. So this is my new hashtag, which is called "Fat is where it's at." Okay, and sorry if that's a little bit a little second grade of me, but anyway. But that's the reality. And when we're harvesting adipose tissue, we're harvesting from beneath the level of the superficial fascia. So the sweet spot is down lower. There are a lot of inexperienced and novice teachers of this art who are saying that you should aspirate from the subcutaneous tissue. That's a problem because there's lots of blood vessels here, and there can be lots of bleeding. And also, when you aspirate adipose tissue from this area, you can create significant contour irregularities. Whereas if you harvest adipose tissue down lower beneath the fascia, you're going to get a lot less problems with bleeding, with hematomas, and you're going to get a much higher concentration of mesenchymal stem cells than you would if you were in the superficial plane. So what is nanofat? So nanofat, we take adipose tissue that's harvested through very small cannulas, 2.4 to 2.1 millimeter cannulas, and then we run this adipose tissue through lower-to-lower transfers, and then we put it through a nanofilter. And with the nanofilter, we're basically taking all of the stromovascular fraction, and we're leaving behind all of the fibrous components and blood vessels and things that are not necessarily less than 400 or 500 microns in diameter. So the only thing coming through is the stromovascular fraction, and there's no fat in nanofat. So that's kind of a very important point, is that it's a misnomer that really is almost purely stromovascular fraction and not fat. So that now when we talk about stem cell physiology, this is probably one of the most important slides of the whole talk. What do stem cells do? Okay, this is really the heart of it right here. They regenerate tissue. They differentiate into certain tissue types. They are able to home to the areas of injury. If somebody has a stroke and you give them stem cells in the vein in their arm, the stem cells will collect around and migrate to the area of the stroke. So the stem cells know to go to the area of injury. If there's a fracture in the leg, we see the stem cells concentrate around the fracture site. Within 21 days, there are like no stem cells that are tagged anywhere else in the body. They're all around the fracture site. Also, anti-fibrosis. I think this is really the key to this talk tonight. Is we saw during COVID that administration of stem cells, exosomes, and other regenerative products, IV, made scar tissue disappear. Now, medical students and doctors are taught that ARDS and anti-fibrosis is incurable. Well, guess what? The books are wrong, and the books need to be corrected so that we can say that there is a cure for fibrosis. There is a cure for scar tissue, and it's called regenerative medicine. Stem cells are also extremely angiogenic. If they're in an area of hypoxia, the VEGF secretion increases dramatically. So the stem cells are actually more active when there's less oxygen. Also, we see tremendous analgesia. We have noticed this a lot. I actually have a colleague in San Francisco who is a plastic surgeon, and his entire practice is for pain management using microfat, using nanofat and PRP combined to get rid of chronic pain. And it's been very effective. And even the patients that I inject the scar tissue, the first thing that they say is, Doc, the pain went away, like within a week or two. And I tell them, I don't believe you, come back and tell me that in a week. I think it's a placebo effect. But the reality is that the analgesic effect of stem cells happens within 2 weeks, whereas the anti-fibrosis doesn't happen for about 9 to 12 months. So we're seeing both of these phenomena, and they definitely happen at specific time periods. The other thing that's really important is immunomodulation and immunotolerance. So we're going to be able to use exosomes and stem cells to treat transplantation patients who have had any kind of organ transplant, and they're not going to need immunosuppression because they're going to be able to be immunomodulated and have immunotolerance without immunosuppression with the effects, the regenerative medicine effects. So immunomodulation is a very important point as well. Okay, now let's get to PRP. Since this is an EmCyte webinar, I think I would be in bad shape if I didn't comment on the magic of PRP, but there certainly is. And what we say is that platelets are known as the regenerative powerhouse of the body. As soon as they come in contact with thrombin, collagen, ADP, a number of other uh, uh, of other substances, that basically the platelet will degranulate, and you can see that these granules are being released. Some of them are exosomes because they're under 200 microns, but then there are others that are basically nanoparticles, and are apoptotic bodies and are considered the secretome, but are bigger than 200 nanometers, which is the limit for exosomes. So we're not just talking about exosomes here, we're talking about the entire secretome, and platelets release a lot of secretome, as do the stem cells themselves. So platelet cytokines, growth factors, chemokines, all different regenerative factors are released when platelets are degranulated. And basically, PRP is just a component separation of the blood, so that we have the platelet poor plasma on the top, and then we have the buffy coat, which is the platelet-rich plasma, and then we have the red cells, which are down below. We basically have in the PRP, we have the growth factors, we have granulocytes, we have monocytes in there, and now what EmCyte has done, which is really brilliant, is and I've always thought that why would you throw the PPP away? It's like you're throwing away the baby with the bathwater. So, because you know, uh, PRP and all of this blood component separation is really done by phlebotomists and by perfusionists. So the perfusionists have actually found a way to concentrate in the PPP some very important anti-inflammatory components. So we have beta-2 macroglobulin, we have alpha 2 macroglobulin, and we have fibrinogen and albumin that are in the PPP. And so what happens is with this protein-rich PRP is we're dehydrating the platelet poor plasma, and we're concentrating the A2M, the alpha 2 macroglobulin, as well as the albumin and fibrinogen. So we're concentrating these, and then we're adding them back into the PRP. And that's why we have the term protein-rich PRP, because we don't just have PRP, we also have the very powerful anti-inflammatory components, which are part of the platelet poor plasma, and we're adding them back into the PRP. So it's been very exciting, and PRP has been shown scientifically to regenerate tissue, to result in anti-inflammation, very antimicrobial. There are PRP wound dressings which are FDA approved for minimizing infection by using a PRP platelet gel to put over top of the wound and minimize the possibility for infection. Also, angiogenesis and hemostatic are very important points related to PRP. But it is important to also point out that PRP does not have any stem cells in it. So PRP is really kind of like a synergistic component to work with the adipose stem cells and to work with the secretome that is delivered from the adipose stem cells. That's really where the PRP comes in very handy, is in the kind of the synergistic effects with adipose stem cells, and not just by the PRP effect by itself. And you can see this is a video which shows the platelet poor plasma, which is being drawn out. And in that platelet poor plasma, we have the beauty of the A2M, fibrinogen, albumin, and then those are added back into the PRP. So it's a wonderful addition and kind of modification and upgrade of the PRP itself. Now, the other thing that's very important is the PRP validation. We hear lots of things in the literature about PRP does not work and it's not, a useful thing. But none of these papers that have negative comments about PRP talk about the validation. And so what are they talking about? What are they injecting? What are they using? They don't even know. So the beauty of the EmCyte system is that there really is no PRP system on the market that actually can stand up to the results and walk the walk, not just talk the talk. And so we have a printout of all of the different components of the PRP. So we have the monocyte count, the granulocyte count, the hemoglobin, the platelet capture, and then afterwards, when we spin the blood down, then we have the post-spin. So we have pre-spin data and we have post-spin data, and we're able to show that we're using platelet concentrations and platelet captures of like 15x with 20 plus billion platelets delivered to the area. So if many of the people I think on the webinar tonight work in the musculoskeletal space, and to be able to deliver that many platelets, that's really the name of the game in PRP. He who has the most platelets wins. That's basically the situation. And EmCyte has proven objectively with this data that they have we are delivering the highest platelet count, and we can even modify with higher or lower monocytes, higher or lower granulocytes. And this is just a great way to finally scientifically and objectively show the benefits of PRP, instead of saying it just doesn't work and not having any data to show what you actually injected into the patient. So then once we have the PRP created, now we take the microfat which has been harvested by small cannulas, and we then change that and convert that into nanofat. So the way that we do that is by going through a serially smaller lore-to-lore transfer, so we can get the adipose tissue. We're destroying the fat cells, and we're concentrating the stromovascular fraction. Now, as soon as you add PRP to the microfat or nanofat, then the PRP will activate. So you only have about 30 seconds to get that combination into the body. So first you have to emulsify. So you have to kind of combine the PRP and maximize the interface between the platelet-rich plasma and the nanofat. And then once you have that, then you're ready to inject, but you need to do it quickly. So if you have multiple joints that you're injecting, you don't want to mix the PRP with the nanofat, all of it at the same time, because it will coagulate and you won't be able to use it for the subsequent injections. But if you mix as you go, then that's the way to do it. So you're not coagulating, and you're able to use this biologic and inject it smoothly without having coagulation in the syringe. So this just shows the kind of gentle mixing that we do with lure-to-lure transfers. And then this is actually how the procedure is done itself. So this is a combination of platelet-rich plasma, protein-rich, platelet-rich plasma, and nanofat. And what we're doing here is we're using single-use disposable cannulas, and we're injecting deep to the scar tissue itself. So we're injecting into the subcutaneous plane. There's no cutting. There's no skin grafts. There's no removing of the existing scar tissue. And you can see in this particular patient that he also had a severe burn, not just on his face, but on his nose, his eyelids, his hair, his ears. So basically, we're injecting this biologic into the subcutaneous space in all of these different areas. So we can go from the nose to the eyebrows to the eyelids, and we're just injecting not for the purposes of filling, but for the purposes of anti-fibrosis, for the purposes of immunomodulation. This is a way to kind of cool off the inflammatory component, the cytokine storm, as was identified and described with COVID lung disease. We're basically eliminating the cytokine storm, where we're immunomodulating and we are anti-fibrosing. So we are getting rid of the scar tissue. And again, the analgesic effects take place within weeks, but the anti-fibrosis we need about 9 to 12 months for the anti-fibrotic effects to take place. And this just shows injection into the scalp for hair restoration using PRP and adipose tissue. And there are some areas of the body where you can't use a blunt cannula, such as in the scalp. So there are areas where we have to do sharp needle injection of this combined biologic. But you can see that with the blunt cannulas, these patients are awake. And so we are now doing these procedures in the office, very well tolerated. Patients are not having any discomfort because the cannulas are blunt, and there's no hematoma, there's no bleeding or damage to blood vessels or vascular structures with these blunt cannulas. So you can literally have the patient wide awake. You can do these procedures without a lot of pain, and the patients really like to not have to, undergo anesthesia. So that's kind of the biology of it, and I want to spend the last maybe 5-10 minutes just to talk about some cases and some outcomes. So this is a patient who had a lime burn of his arm, a black patient, developed keloid, but he said that the most horrible thing was his neurogenic pain. He could not get out of bed in the morning without wrapping his arms in Coban for compression, because he felt like people were sticking knives and ice picks into his arm, like incredible pain. So I let this patient know that we don't really, we're still, the science is evolving, but we're going to try to inject some stem cells and EVs from his adipose tissue, combine it with PRP, and we'll see how it goes. And 2 years later, you can see that the scar tissue is dramatically reduced. And to this patient, the most important thing was he got out of bed in the morning with no pain. And his other doctor said, "That's it. You're done. This is it. There's nothing else to do for you." And so he was really depressed, thinking he's got to live his whole life with this horrible, unremitting pain. He didn't even really care about the keloid appearance of the scar, but we were able to get him complete, from a 10 out of 10 in pain to a 0 out of 10 in pain. And, it was just very, very life changing for this gentleman. He was happy to get the scar appearance of the scar, improved, but he was very happy to get rid of the chronic pain, which happened within a matter of weeks after the injection itself. Because breast implant capsular contracture is really basically scar tissue forming around the implant. So I have used this and brought this technology, expanded it into the world of plastic surgery, because when you take an implant out and you put in another implant in and you hope that it's not going to scar in, we say that hope is a bad surgical principle. We don't like to hope that anything will be better or wish that anything will be better. We want to just know that it will be better. So injecting this anti-fibrotic material around the breast implant capsule, getting rid of the capsule and preventing it from recurring. This is a patient who's 2 years out, and you can see that her left breast capsular contracture is resolved and has not recurred. And recurrence is the common theme with breast implant capsular contracture. This is a patient with a hand keloid, and you can see I told the patient, don't expect anything for 9 months. He called at 6 months and said, "Hey, doc, I'd like to come in because I'm seeing that my scar tissue is going away." So even at 6 months, we see a decrease in the thickness of the scar and a softening of the skin in the region of the scar. And these are just great examples of the anti-fibrotic and anti-inflammatory processes of the combination of nanofat and protein-rich PRP. This is a guy who came in who had horrible industrial burn to the hands. You can see injecting nanofat and PRP. You can see it's just amazing just to the pigmentation, how that pigmentation has improved over the whole hand, all the way down into the fingers, and the scar tissue and the ridges of scar tissue have basically gone away. And I think, you can see it here significantly with this big wedge of scar tissue that's really starting to melt away. And I think where you can really see it is here on these. If you see this ridge of scar tissue, this is his right hand. This is an oblique view from the right hand. You can see the really horrible and the big ridges of scar tissue, especially on his middle finger and his index finger. And you can see that all of that has basically gone away. This ridge of scar tissue is now soft, supple skin. And you cannot get this with any skin graft, with any surgery, with any laser. This is only effectively treated with a combination of biologics, nanofat, with mesenchymal stem cells and extracellular vesicles, EVs, combined with the secretome of the platelets and protein-rich, platelet-rich plasma. This is my first patient who I did about 15 years ago, and he had a propane explosion. He was having a barbecue with his family, and you can see the ridge of scar tissue here. He had two complaints. One was that he couldn't open his mouth, so he couldn't brush his teeth and he couldn't eat. And the other thing was that his ear was burned to the side of his head, so he couldn't wear his glasses and he couldn't read the paper. So he couldn't read and he couldn't eat or take care of his oral hygiene. And after injecting this biologic underneath the scar tissue, as you saw in the video, we have dramatic resolution in the amount of scar tissue. And I think you can see it here on the close-ups. You can see that, this is the scar tissue, thermal burn, very severe, not able to open his mouth. And then here we have injecting into the scar tissue, and now the patient is able to open his mouth, he's able to brush his teeth, and he said, "Guess what, Doc? I'm also reading the paper now. I'm a happy camper because that whole cord of scar tissue that was above my ear has completely disappeared. I don't know why, I don't know how, but it's just amazing that I can wear my glasses and I can open my mouth now." And I presented this case to a bunch of the dermatologists at the University of Miami and dermatologists around the country, and many of them know this patient. They treated this patient. They tried to use lasers on this patient. Nothing was successful. So that when I lectured at a big dermatology conference, the dermatologists, the world-class dermatologists in the crowd were looking at this because they know the patient, they know his name, they know that he has failed every treatment that they've offered. And so then I get a storm of calls from dermatologists and questions after the lecture asking, how do you make this scar tissue disappear? We can't, we have no technology to do that. And I'm basically saying now we do have technology to do that, combining nanofat and protein-rich PRP. And I'd also like to say that PRP in general is not, standard across the board. There are PRPs that have 1x platelet concentration. There are PRPs that have, a beautiful concentration of platelets, such as as the EmCyte protein-rich PRP. So you can really see that PRP is not PRP is not PRP. So just because someone says they use PRP, that's like saying all cars are the same. Well, a Rolls-Royce is different than a Chevrolet. You could say, oh, they're all cars, they're all the same, but they're not all the same. And PRP, the products are not all the same. And that's really, I've used every product and every device on the market, and there is nothing that compares to the protein-rich EmCyte PRP technology that's out there. And if I wasn't getting these great results, I wouldn't be here talking about this right now. And then you can see here the demarcation between the thermal burn and the normal skin. And you can see here that after the patient had several years of therapy and no improvement and some worsening of the scar tissue, then he now comes in my office with a big smile for the first time. So that was very striking to all the dermatologists who unsuccessfully treated this patient and couldn't get his scar tissue to go away. And now we are able to do that with this combined biologics. So I'm just going to end by making a shameless plug for my book that we recently published with Dr. Marks, who was actually the kind of the original describer of platelet-rich plasma. He actually wrote the publication called PRP is not PRP is not PRP. And, it's just a wonderful thing to be able to combine stem cells, particularly from adipose tissue and their EVs, with such a great PRP product. And Dr. Marks actually took care of this patient's wife because she had a sarcoma of her mandible. Talk about an unlucky couple. And when the patient and his wife went to see Dr. Marks for her follow-up, Dr. Marks said to the husband, "Where are all your scars? What happened to all your scars?" And the patient said to Dr. Marks, "Oh, Dr. Miller is making them go away with stem cells." And Dr. Marks says, "Oh, that's interesting because I just wrote a book with Dr. Miller, so I'm going to have to ask him about that." So we're really getting some great results and great feedback from the patients. Also, we created a website called an internet portal called stemcellreference.com. This was created in 2016, pre-COVID, with the blessing of the FDA, with the blessing of the NIH, with the blessing of many big academic centers, and it's a peer-reviewed source for accurate stem cell information. We have 800 Google landing pages. We are in 5 continents. We have thousands of unique visitors from 5 continents, coming to the site. And after COVID, when everything shut down and the world shut down, the only thing that didn't shut down was the internet. So now we have 95% of our visitors are finding us organically just by searching the word stem cell, not by searching stem cell reference, because no one's ever heard of stemcellreference.com. So now we have hit the top of the organic search engines. So people are finding us all over the world 24/7, 365 by just typing the word stem cell. It has links to the FDA, it has links to clinicaltrials.gov, to PubMed. There's no charge for this. It's mobile friendly, and we have 21 different languages. It's even allowed in mainland China and has been visible and viewable in mainland China for since its inception in 2016. So I would encourage anyone who is interested. There are 4 platforms. There's doctors, patients, research, and industry. In the each platform, everyone can look at everyone else's platform. So the patients can look at the doctor platform, and the doctors and the researchers and industry can look at the patient platform. And it's just turned out to be a really great resource for anything that you need. Companies related to stem cell equipment, attorneys and regulators related to stem cell regulation. So it turned out to be a great resource, and this is not anything that generates any income for us, but it is a great resource, and we have doctors, researchers, and regulators from all over the world, so that everything that is on this site is peer-reviewed and vetted before it becomes visible to the public. So with that, I'd like to say thank you very much and open up. I went a little bit long here, but I wanted to just kind of include everything and then just open the floor up for any questions that anyone might have. So thank you for your attention.
Thank you so much, Dr. Miller. Those were striking outcomes. Those were excellent. Thank you for sharing those with us. We do have one question. We can take that question really quickly before Dr. Farzaneh presents. So we have someone asking, please discuss FDA regulations around creating SVF via mechanical means versus enzymatic means. And it's a two-part question. Next is mixing PRP and nanofat not creating a drug per the FDA?
Okay, so the I guess the first question, could you repeat the first question
Yeah, so the
again?
first part is what are the FDA regulations around
Okay,
creating SVF via mechanical versus
mechanical versus.
enzymatic means?
Okay.
Yeah.
Okay, got it. So basically, the FDA is all about manufacturing. If you're going to start manufacturing a drug, then they're going to have to be regulating that. So when we do enzymatic digestion of adipose tissue, we are using chemicals. We are manipulating that tissue, and that's more than what's called minimal manipulation. So anytime you exceed minimal manipulation, you're manufacturing a drug, and that drug needs to be regulated by the FDA. Now, when we're doing just physical emulsification, and we laughed at the FDA said, we don't like the word emulsification. So we said, how about resizing? And they said, yes, we love resizing. That's perfect. So now we realize that if we resize adipose tissue, we don't emulsify, quote unquote, but we resize it without enzymes, and we're using it in the same patient, in the same day, in the same procedure, which is called the same day surgical exemption, then we are able to use these biologics as the practice of medicine with minimal manipulation. And then I asked Dr. Marks himself about combining PRP, minimally manipulated platelet-rich plasma with minimally manipulated adipose tissue or nanofat. And basically, the FDA's, I guess, perspective or kind of like their feeling on this is that these are both minimally manipulated materials, and so there's room for discussion there. That was what Dr. Mark said, that it was not really considered to be a violation of the current standards because everything is minimally manipulated and is created during the same procedure with the same patient and the same day's surgical exemption. So we have very good dialogue with the FDA, and they are understanding what we're doing. And I made the point actually to Peter Marks directly from the FDA to say that, surgery, we combine tissues, we chop things up, we slice things, we dice things, we emulsify things, but that's all in the practice of surgery. We've been doing that for, hundreds of years. So we're not manufacturing a drug when we chop up cartilage or bone graft and we mix it with PRP. That's not creating a drug. That's basically the practice of medicine. So we're in good stands with the FDA, and we also have very, very good relations with the FDA. So we're actually helping them to kind of define the guidelines and to make sure that practitioners are following, the proper directives from the FDA. But we are uh, doing these procedures with great success. The FDA is noticing, and there have been really no objections or any kind of warning letters or anything from the FDA. So we have good dialogue, and we think that we're continuing with the practice of medicine. We're not manufacturing a drug at this time.
Okay, great. Thank you. And one more quick question. So a little bit of clarification. The results that you see as far as the reduction of the fibrous tissue, is that after one single treatment, the 9 to 12 months window? Is that one treatment?
Yes, amazingly, it's like one and done. And
Oh,
it's,
wow.
even the cardiac injections that we're doing at University of Miami, it's like inject the heart with stem cells. This is drug studies, okay? These are maximal manipulation and FDA regulated, but basically we're injecting the heart muscle after myocardial infarction where there are scar tissue in the heart, and the patients basically get one injection and they're done. And then they come back to the cath lab and they come back and get their 3D CT scans. And it's really a single treatment modality. Now, the patient that had the really bad burns on his hand, who was one of the last patients that I showed in my lecture, he's the only patient in my career so far that came back and said, "It works so well, I want to do it again." And I and I said, "Well, what do you?" I said, "The stem cells are still working. You're still getting improvement." He said, "I know, but I'm getting so much improvement, but I still have some scar tissue. I still have some limitation of my mobility. Can you do a second treatment?" So that is the only patient that we have ever done a second treatment on. All of these other patients, including the lime burn and the horrible keloid on the arm and the face burn, those were all just one treatment. And that's really what goes to show that, there's a difference between scientists and clinical medicine. The scientists say the exosome just disappears in 30 minutes and that's it, and then that's you're done. But that's not really the end of the story. The end of the story is that the anti-fibrosis and the immunomodulation and the anti-inflammatory effects continue for years after the treatment. So we don't know what the recommendation should be. Should we go back and do a second treatment, maybe for those scars that are really bad and we've accomplished some, good result, but then we want to go back and do more. But for the vast majority of these cases so far, it's been one and done.
Wow, it's amazing. Thank you so much, Dr. Miller. So we're gonna switch gears a little bit, and we're gonna shift to our second speaker, Dr. Farzaneh. And we're now switching over from a clinical approach, and we're gonna hear more about a scientific, mechanistic perspective on scar treatment and scar pathologies. So I'll switch over to you now, Dr. Farzaneh.
Can you see my screen?
Not yet. Oh,
Yep.
yeah. There we go.
Perfect. Hello, everyone, and thank you for joining us for the Regenerative Age EmCyte monthly webinar series. Thank you as well to Dr. Miller for sharing his valuable clinical insights and treatment protocol. Over the next 15 minutes, I would like to focus on the pathology behind different scar types and how understanding those differences can help us select the right biologics treatment or a combination of the treatments, as Dr. Miller mentioned, for each patient. I will also briefly cover some of the molecular mechanism involved. So let's start. Okay. Let's start with the scar classification. Scar type varies a bit by sources. The American Academy of the Dermatology lists them as a flattish scar, raised or hypertrophic scar, depressed or atrophic scar, keloid scar, contracture scar, and stretch mark scar. I want to note this, we categorize acne scar in one of the atrophic or hypertrophic scar based on the nature, the scar tissue and the feature of them, because there is kind of mindset in the society when we talk about the acne scar. Mostly we refer the acne scar toward the atrophic scar, which is not correct 100% because we also have the hypertrophic scar in the acne scar. So just to have a quick review, this slide shows the normal healing as a controlled sequence. It starts with the hemostasis, then moves into inflammation, then proliferation, and finally remodeling. This is the steps and phases we're seeing after the injury toward the wound healing. Early on, immune cells come in the injury site to clear bacteria or damaged tissue, and macrophages help organize that responses. What makes normal healing successful is that macrophages do not stay inflammatory forever. They transition the wound into the repair. Once inflammation resolves on time, signals like interleukin-10 and probably regulatory T cells support a pro-resolution anti-fibrotic macrophage state that lets the maximal efficacy of the healing, and that lets the matrix form in the controlled way and then remodel properly rather than being excessively deposited or broken down, which we see on the hypertrophic scar or acne scar, respectively. However, wound gets trapped sometimes in inflammation instead of the progression into repair. The bacteria biofilm or other microbial factors can keep stimulating the immune response. So neutrophils or other leukocytes continue releasing ROS and ETs and proteases, which progressively damage the extracellular matrix and also destroy the growth factors needed for healing. At the same time, fibroblasts became senescent, so their ability to rebuild tissue is reduced. and macrophages fail to fully switch from the pro-inflammatory state into a pro-healing state. The results in that tissue breakdown becomes greater than tissue replacement. So this failure of the matrix regeneration leading to tissue loss rather than excess scar formation. So here we have high activity of the proteases from both neutrophil and macrophages, mainly MMPAs, matrix metalloproteases, and they degrade the ECM. We see this in atrophic scar. In another scenario, actually, I wanted to mention the key player in this scenario for the atrophic scar are the leukocyte, mostly neutrophil, MMPAs, and also other proteases. In another scenario, when wound stays in the profibrotic environment, where inflammatory macrophages are pushed into profibrotic macrophage phenotype, and that becomes a major engine of the scar formation. These macrophages keep reinforcing TGF-beta 1 signaling along with mediators like interleukin-6, interleukin-8, which drives fibroblasts to become scar-forming myofibroblasts and deposit excessive extracellular matrix. At the same time, mast cell degranulation adds another strong fibrotic stimulus by releasing TGF-beta 1 and profibrotic proteases, which further amplify fibroblast activation, contraction, and collagen buildup. So instead of stopping once repair is enough, the tissue keeps laying down matrix and thickening the scar, and that is how a hypertrophic scar forms. The key player in this case are going to be mast cell, TGF-beta, which is very, very important to consider that, and fibrotic macrophages. So now, since we know the key players behind the pathology of the atrophic and hypertrophic scars, let's look at the regenerative biologic options. The first one is PRP, as Dr. Miller also mentioned. If I think about the target tissue here, which is mainly skin, PRP makes sense because it provides a concentrated matrix of the growth factors that directly support repairs. It gives PDGF to recruit the fibroblasts and endothelial cells, VEGF to support angiogenesis, EGF to promote keratinocyte migration and re-epithelialization, and IGF with basic fibroblast growth factors to support the fibroblast growth and granulation of the tissue and tissue formation. But PRP also has TGF-beta, which is very important to think about that, because although it helps regulate the inflammation, guide the matrix deposition and remodeling, TGF-beta has a dual and highly context-specific role in PRP-based scar management. In atrophic scars, its effects on the inflammation modulation, fibroblast proliferation and migration, and extracellular matrix deposition may support the tissue regeneration, and we are seeing the outcome from the literature and clinical reports with a great outcome when we are using the PRP with the high dose of the PRP because of the TGF-beta and other growth factors to treat the atrophic scar. However, in hypertrophic scar, TGF-beta is already a center of the mediators of fibrosis and scar pathology. So excessive exposure may worsen the process rather than improve it. This highlights the importance of careful PRP dosing in skin and soft tissue applications. Unlike musculoskeletal indication that Dr. Miller also mentioned, where higher platelet delivery is often pursued, hypertrophic scar treatment may require a more controlled approach, as a higher platelet dose is not necessarily advantageous for every cases, every indications, everywhere. So we need to be careful. Another option is going to be MFAT or nanofat. I see them more are cellular and stromal regenerative platform. They bring adipose-derived stem cells, stromal vascular fraction cells, and microvascular fragments. So they are not just delivering the signal, they're also creating a biological niche that supports vascularization, immunomodulation, and tissue remodeling. So this is very special and interesting for the hypertrophic scar treatment using the adipose-derived stem cells because, as we mentioned, TGF-beta is one of the detrimental factor for the hypertrophic scar. When we apply the adipose tissue product like nanofat, based on some preclinical study and in vitro study, it is verified adipose-derived stem cells can minimize the availability and bioactivity of the TGF-beta. So when we apply that, even in combination with the PRP, we are not going to be worried about the TGF-beta of the PRP because adipose-derived stem cell can minimize the influence of the TGF-beta, which is not good in the hypertrophic scar. And by minimizing them, also gives us that possibility and chance to get the maximal benefit from other growth factors of the PRP. And the third option, as Dr. Miller mentioned, is the concentrated plasma protein, which I think more of the protective and anti-degradative approach from the component of the concentrated protein, plasma protein. It provides A2M, alpha-2 macroglobulin, and different serpin proteins to control excess protease activity, which is very good because in the atrophic scar, we're seeing the high activity of the MMPAs and proteases, and with these proteins, we can take care of them. Also, it gives us a high concentration of the other protein, which I'm going to talk about, like BMPs, protein bone morphogenic proteins, family BMP2, BMP4, BMP7, alongside the PRP and also alongside with the adipose-derived stem cells, which is very essential and useful when we are dealing with the hypertrophic scar. I'm going to talk about that in the next slide. So, if we look at the fibroblast as one of the key player during the hemostasis, tissue regeneration, wound healing, and possibly scar formation, we can see normal wound healing fibroblasts differentiate into myofibroblasts under the influence of the TGF-beta. TGF-beta actually initiate a couple of different signaling pathways to accelerate and enhance the differentiation of the fibroblast toward the myofibroblast. Okay, most of the TGF-beta in this case get released from the macrophages, specifically profibrotic macrophages. This differentiation is characterized by the increased expression of the collagen, fibronectin, and TIMPs, which is the tissue inhibitors, metalloproteases, together with the formation of the alpha SMA stress fibers within the myofibroblast. Upon the cessation of the wound healing, I mean the end of the wound healing, myofibroblast undergoes apoptosis and the tissue gradually returns to the near normal architecture. This is the normal wound healing process. In the normal wound healing process, definitely we are seeing the myofibroblast, but at the end of the procedure and process of the wound healing, we should get the apoptosis of the myofibroblast. But in aberrant wound healing, however, myofibroblast fail to undergo apoptosis and instead persist within the tissue. Their continued survival drives ongoing extracellular matrix production and contraction, leading to progressive matrix accumulation, increased tissue density, and ultimately the formation of the hypertrophic scar. So we should consider the myofibroblast as the target for the treatment of the hypertrophic scar. So long before the mechanism of the regenerative biologics were clarified specific for scar management using these combination of the biologics, clinicians had already observed the autologous fat grafting improved the scar quality in plastic surgery practice. The main drawback was the rapid and unpredictable resorption of the graft, largely related to the inconsistent vascularization. To improve graft survival, PRP was added clinically, and the PRP and actually PRP enhanced fat grafting showed better retention and scar outcomes than fat grafting alone. So subsequent mechanistic studies suggest that this benefit are linked to targeting the myofibroblast axis. Adipose tissue and adipose-derived stem cells can reduce myofibroblast persistence and profibrotic signaling. When we add the PRP to the nanofat or MFAT, actually adipose-derived stem cells minimize the function of the PRP's TGF-beta while using the benefit of the BMP proteins, bone morphogenic proteins of the PRP. And if we add the concentrated protein, which Dr. Miller added to the treatment, BMP proteins, mostly BMP2, BMP4, and BMP7 of the concentrated plasma protein, PRP, and adipose tissue can initiate the de-differentiation of the myofibroblast toward the adipocyte. It's a kind of reverse of the scar. Moreover, studies showed that PRP stimulates adipose-derived stem cells to produce a 5-fold increase in expression of the BMP2 and BMP4. So now the combination of them is very, very reasonable, and it has solid, actually, a rationale behind of that based on the in vitro evidences and a study. Another mechanism is related to the to this de-differentiation of the actually myofibroblast and minimizing the TGF-beta activity is related to the hepatocyte growth factor, which we have in the PRP, concentrated plasma protein, and also adipocyte can produce the hepatocyte growth factor. It has been shown that hepatocyte growth factor can interact with profibrotic molecules such as TGF-beta and connective tissue growth factors in surrounding microenvironment and decrease their expression. So takeaway from these scenario, we depicted in this story, not all the scar are biologically the same. When we are going to treat the scar, we should first consider the nature of the scar, which is if the atrophic scar or hypertrophic scar, based on different mechanism of the pathology, we have to decide the different bioformulation or combination for them. As we see in the atrophic scar, mostly we have ECM degradation because of the high activity of the MMPase and proteases. So probably higher dose of the platelet and the combination with the concentrated protein, which enriched with the anti-proteases protein, would be very, very beneficial. And the hypertrophic scar, definitely combination of the PRP with the adipose-derived stem cells, and recently, based on the protocol Dr. Miller and EmCyte developed together based on the protein-rich PRP, which added the concentrated plasma protein, we can get the maximum benefit. Myofibroblast is the major therapeutic target, and we already saw the rationale and mechanism of action behind of the treatment by targeting the myofibroblast. And the combination approach, such as PRP plus fat-derived product connected with the concentrated plasma protein, may work synergistically by promoting regeneration while reducing fibrosis and matrix destruction. Thank you for your attention.
Thank you so much, Dr. Farzaneh, for the mechanism perspective. That was very insightful, and it certainly goes a long way to understanding the pathology and the treatments. So we do have more questions. As far as is nanofat preferred over MFAT for scar tissue treatment because the nanofat is mostly SVF and thus higher has a higher number of MSCs?
Yes, I'm assuming that question is for me, and the answer is
Yes, yes,
yes.
Dr. Miller.
And the answer is yes, no question about it.
Okay. And then I was curious, so in the MSK field in particular, there is a growing consensus now in terms of platelet dosing and the standards are a little bit more defined. And I was wondering if there is something similar happening in the cosmetic surgery field or reconstructive surgery. Are you starting to see any kind of platelet dosing standards emerge?
No, I mean, I would say that the concept of even combining PRP, platelet-rich plasma, or protein-rich PRP, and nanofat is not really something that is well understood by the vast majority of plastic surgeons and or dermatologists for that matter. So, we are working towards developing some standards for that, but at this point, there's so little experience with those biologics in the world of plastics and dermatology that they're very far away from, developing some kind of a standard dosing schedule. The other thing that is difficult is that you say a dosing schedule, but then is it related to the quality of the PRP itself? If you
Mhm.
say, should it be 20% PRP and 80% nanofat? Well, what kind of PRP are we talking about? Is it a PRP with a 1x platelet concentration? Is it with a 15x platelet concentration? So there's a lot of variables and a lot of unfamiliarity. So at this point, there is not any specific protocol or regimen, and we hope to kind of move towards that so that we can give some standards in the industry for other practitioners to be able to, reproduce the results that we're seeing.
Great, thank you. If we have any more questions, now's the time. I know we're a little bit over, but feel free to send one last question in. And I can quickly do some announcements before we wrap up this evening's session. And let me just go ahead and share my screen really quickly. Can everyone see the screen?
Yep, yep.
Great. First, upcoming events. We're having a Precision in Motion conference, and it's going to be held at the Gulf Coast Biologics Conference Center in Fort Myers. And it's going to be the first weekend in May, the 1st to the 2nd. The topics that are going to be covered are adipose harvesting, bone marrow aspiration, nerve hydrodissection, spinal injections, and ultrasound guided injections. So head to the Gulf Coast Biologics website and register. These are our faculty who will be there. Dr. Miller, of course, will be there. And we have Michael Meng, Dr. Farzaneh, Dr. Rowan Paul, and Dr. Irizarry Roman. So please go to the website, Gulf Coast Biologics, and sign up for this conference. It's coming up soon. There's also free ultrasound training held at GCB monthly. You can always go online as well, register. And once again, let me just remind everyone these are free, so please take advantage of that. Uh, Dr. Miller talked about using the protein-rich PRP in combination with a nanofat or scar treatment. To make that protein-rich PRP, this core ultrafiltration system is key and is available in two sizes. These can be ordered through EmCyte sales. And of course, the concentrating systems from EmCyte. Please note, EmCyte will be switching over to primarily the pure super physiologic concentrating systems with the Aspiridome technology. We're switching over exclusively for preparation of pure PRP and pure BMAX. So please switch over now. You will not be disappointed. It's a fantastic system, as I'm sure many of you have already encountered it and you're familiar with it, and it works fantastically well. So please switch over as EmCyte switches over. We also have the EmCyte Power Sales app. I have a brief video that explains how the app works. I'm gonna just show that now, and that will fill you in on how this app works as far as ordering through EmCyte.
EmCyte has launched the new Power Sales mobile app, making it even easier for you to manage your biologic orders and resources right from the palm of your hand. You can download it today from the Apple App Store or Google Play. To get started, simply use the Enroll feature so we can set your perfect price and securely connect you to EmCyte Biologics. Once you're inside, you'll notice it brings all our most powerful tools directly to your phone. Just by tapping the icons, you can instantly shop for products, access valuable resources, including clinical publications, instructions for use manuals, and processing videos. Or open the new PRP calculations tool. P-Calculator, simply enter your baseline and result information, and the app instantly provides your yield, concentration, and deliverable cell content, eliminating manual math completely. You can also tap into EmCyte Data Biologics to easily track patient outcomes. The software sends automatic pain and performance surveys straight to your patients, and it's completely free for EmCyte users. Need to report an experience? The complaint feature lets you submit details and shoot a video right on the spot. If you'd still prefer to use a computer, no problem. All Power Sales features are fully operational online at emcyte.net. Download the app today on iPhone and Android.
All right, thank you. So we'll stop there with announcements, and if there are any more questions, let me check really quickly. Yes, we do have a couple more. So one question is, Dr. Miller also, where can the blunt tip cannulas be sourced? Does it require a stab incision to introduce into the skin?
Yes, well, actually, I usually use like an 11 blade to just do like a tiny little nick, and typically those are not even closed with sutures because they're so small. And the blunt cannulas that we're using are manufactured by Tulip Medical in San Diego, and I know that that EmCyte and Tulip have a strong, long time working relationship. And the single-use disposable blunt cannulas are definitely the way to go for these procedures. I think it improves the clinical outcome and also, the safety factor and not worrying about infections like mycobacterial infections and things like that. So the single-use disposable cannulas from Tulip are really good to use, and I typically will use their disposable infiltration cannula, the disposable Miller harvesting cannula. That's to get the adipose tissue out, and then the nano transfer system and the lord-to-lord transfers, and then for the actual injection subcutaneously, I will typically use a 17 gauge Tulip injector to inject the combined biologic of protein-rich PRP and nanofat using that 17 gauge cannula with a specified ratio, and then just injecting that into the subcutaneous tissue underneath the scar itself.
Thank you. And one final question again, Dr. Miller. Have you noticed any success with flexor contractions of the fingers with PRP and nanofat application?
Absolutely. This is going to be a revolutionary treatment for Dupuytren's contracture. I'm a hand surgeon also by trade in Texas when we were doing, these really horribly morbid procedures to try to release patients' Dupuytren's contractures with Z-plasties and lots of grafting and lots of morbidity. these were really, really difficult procedures for the patients to tolerate. Now we're basically taking nanofat PRP, maybe doing a little bit of lysis of the scar tissue with just a needle subcutaneously under the skin. But for the most part, the biologic is really anti-fibrosing the area and resolving and curing basically the Dupuytren's contracture. So I do think that that is something that's very exciting and on the forefront, and it fits perfectly with the biologic properties that we're that we're talking about. And also, I just want to comment, because I don't know that I'll get a chance at the end, just to thank Sina for the scientific approach, and understanding, because when I see those slides, it really makes me understand, what it is that I'm doing, physiologically. And even tonight, I learned some really great things from Sina. So I think, having the basic science and the scientific input is really key, because we're not shooting in the dark. We're really understanding physiologically what's happening. And every time that I interact with Sina, I learn more about the physiologic processes and maybe even how to modify our treatment. So I just want to say a thank you to Sina as well.
Thank you to you, Dr. Miller. You are always my mentor.
And then vice versa as well.
Thank you so much to both of our speakers. Those were excellent presentations, truly groundbreaking. And as you mentioned, Dr. Miller, the textbooks will have to be rewritten. And I think this is a good note to end on. Thank you so much, participants, for attending. And we hope to see you at the next webinar series. Thanks so much, everyone. Have a great evening.
Thank you for joining us in this session of EmCyte's Webinar Series. Stay tuned for our next episode as we continue uncovering the science behind precision biologics.